them off, you become more symptomatic, more pruritus, particular. So we try to get them down to the lowest possible dose tolerable, but I think outside of that, I don't think anyone is looking at metronidazole as a long-term or durable evolution.
My experience also is that those patients that have PSC and ulcerative colitis that go on vancomycin, their colitis is much easier to manage. But this is, of course, few numbers. And I don't know whether you agree with that. It seems that they seem to require very little additional treatment.
Well, a number of my patients, I mean, I had one patient on Remicade that was not responding, and this is 3 years later, it's only on Vanco, has had no recurrence of the colitis, and liver numbers are normal. And so most of my patients' colitis, they're only on Vanco. They take them off of everything else, and they haven't had a flare. I had one that did flare.
Yeah, I had a few
that I ended up having to give Remicade because when I lowered the Vanco, she flared and I couldn't get it to go back. But her liver numbers stayed normal. I also want to say I do C19-9 on all my PSC patients, and I have about 8 of them that have high C19-9s, and on Vanco they went to normal. And then the second thing was that I also looked at other factors like leptin. Leptin stimulates cancer growth. That was high and went to normal too on the Vanco. So I also, and we've not seen any cholangiocarcinoma on the Vanco.
Can you explain why there's a higher number of pediatric small duct patients than there are adults? Do they morph into large duct?
Well, maybe that we're diagnosing them earlier, because I think a lot of the adults probably have had the disease for quite a while before they got diagnosed. And I think we're picking up kids when they're 2, 6, 10 years of age, so that may be why. And maybe if we wait longer, the large ducts would be involved as well. I don't know.
Well, I think that's one possibility. The other is there one PSC or more than one PSC? I think for the purpose of studying a medication, I think it would be nice to have the data, but if you want to present it for as a grant, try to make it simple for the reviewer. So just put PSC, whether they have small duct or large duct, you can say we can look at them in terms of looking at data, but we're going to treat both and see if there is a difference down the road.
I really wouldn't exclude the small duct disease because those are the ones that are really very responsive. So,
Do all your patients have colons?
yeah.
I'm just trying to figure, will this work without a colon, or why does it work?
Well, actually, I have
That's a
one.
good question.
I do have one patient that had a colectomy that came to me with PSC,
I don't think I have.
and the PSC went away on the Vanco. And this kid's actually, he's an adult now, he's been on it for about 5 years because, but he had a colectomy.
And I guess for anybody who's been doing this, talk about dose reduction at some point for the people who are responders. I guess what arbitrarily, I guess, is there a time period that you wait where you consider, they're stable and then you would dose reduce, and then how much do you dose reduce?
So I think long term, one is most patients I can reduce the dose, and what I end up doing because of my experience is I wait 12 months before I start doing that. And then what I do is I drop the dose, like if I'm doing 500 3 times a day, I go to 500 twice a day. And I watch the labs for at least 3 to 6 months before I make the next step. Then I go to once a day, and then I wait 3 to 6 months before I do the next step. And then I think about stopping it at that point. And again, I watch it closely because some of the flares may be 6, 12 months later. So I keep watching labs every 3 months when I've stopped it to see if they flare. And there has been a subset that I've had to go to higher doses. I mean, I have about a half a dozen patients, and I've gone up to 1,000 milligrams three times a day because they weren't responding completely to the 500, and they respond to a higher dose. And so that's the other thing to know.
Well, to answer your question, that's why we need this group in the sense that we have followed similar guidelines as Ken has done. I usually will treat them 4 times a day for at least a month, sometimes 3 months before I would reduce. With teenage, I mean, this is not science, this is just the art of medicine. I think that if I usually do not go to once a day because I don't trust a teenager to take things once a day, so I will actually always ask for twice a day dosing. So at least I can think, my thinking is that at least he will get one dose. He or she, will get one dose. Usually it's a boy that doesn't want to take their medicines.
One other observation I've had is that some of the patients that I've been able to take off and they haven't flared, their antibodies all became negative. And so I have a feel that that might be an indication of a higher probability to get off. So that's something I can keep an eye on, are the positive antibodies.
Well, that's something I didn't know, so that's something that we might do to really look at the markers that way as well.
And the other thing is doing colonoscopies on them. A lot of times they're asymptomatic. Their stool calprotectin is not abnormal, but they still have inflammation. And so I think it's important when you're going to start tapering them or take them off the vanco, let's do a colonoscopy, because I think if they still have some activity there, I think there's a higher probability that they're going to flare when you drop the dose or stop it.
And you're talking about microinflammation as opposed to visual or symptomatic.
Yeah, it's biopsy
Yeah.
inflammation. It's not visual.
I have a question about the Mayo Clinic experience. So I know that with Dr. Cox's patients, most of them haven't required immune suppression in addition to vanco. Has that been your experience as well?
That is correct. The only ones that have had requirement for immune suppression were overlap syndrome, and these usually are difficult to treat. Now, there are patients who present with combination of autoimmune hepatitis and PSC, but in my experience, those patients evolve towards more of a PSC phenotype than an autoimmune hepatitis.
I've had one patient with a high IgG4 that had pancreatitis, colitis, and PSC that all responded to the vanco. And I had one other patient that was in Israel that they used vanco on with a high IgG4, and the IBD and the PSC responded to the vanco. So that's one group. And then of my 3 patients that did not have IBD, one of them was PNK positive, even though the scope was negative. So.
In terms of timing of when you start the treatment, I've heard from many patients that doctors want to see symptoms before they start treating. Can you talk to that?
GGT, or speaks louder. So I think if the GGT is abnormal, that's really an indication that there's ongoing liver disease. Chronic liver disease in a variety of conditions is similar to high blood pressure. You really have to check it to find out if you have high blood pressure before you get into trouble. And high index of suspicion is very important with IBD patients.
And I don't think we check liver numbers in our IBD patients as often as we should be doing it, particularly GGT, because I do believe that there may be more PSC out there because they don't have symptoms at all that we're missing. And like this father of this kid I have that ended up having high GGT and PSC on his MRI. So, and I have another family where the dad's had a liver transplant, his brother's had a liver transplant, and the kid, they just happened to do liver numbers because of that, and the kid has PSC. So.
Mark Deneau's paper on the GGT as a response to PSC, he had a very hard time publishing it because the reviewers were mainly adult hepatologists that don't believe in GGT. GGT is inducible enzyme and will go up with alcoholism, you know that. And so that's how they know if an alcoholic is abstinent or not. Among other, it goes up to medications and what have you. So but in patients with IBD with PSC, it's an extremely sensitive test for biliary disease.
I don't know too many. There's I think a lot of pediatric hepatologists out there who, none of us wait for symptoms to treat. And I think, there's a lot of different centers that have used vancomycin, just, what other things haven't worked. And so, nobody, it's just like autoimmune hepatitis, you wouldn't sit there and wait when their enzymes are elevated to treat them, until they, waiting until they become symptomatic. So, and, most of my pediatric IBD colleagues, they're really good. I mean, not now that I just work at Mayo, but the other places I've worked, they're also pretty good at screening GGTs in their IBD kids looking for liver disease. And as soon as they find that it's not normal, they send their kids. And I have another colleague who uses vancomycin who's down in Miami. So, but I think until Mark started to pull all this stuff together, there wasn't, there were just cases here, cases there, kind of thing. Apart from your studies,
in a way, I feel guilty and not guilty for using vancomycin as a treatment option for these patients, because we did it based on Ken's experience, and then we were gratified by the results, and therefore we didn't. But in one could always be a 20/20 hindsight and say, well, we should have done it as a study with double blind and placebo controlled and what have you, which I think is something that should be done at some point. But I think so far we've had quite a bit of data to show that it works. And patients, of course, want things to be working for them.
Yeah, but part of the problem is always trying to get, if you're pediatric, usually they want the studies done in adults first. And it's very hard to fund, and it has to be, because none of us have like a ton of patients at any one center.
Right. Before you came, I was saying that we should become like the pediatric oncology group, where all of us in pediatric liver should have small, big centers. It's not like somebody who's doing 6 transplants, 6 to 8 transplants versus 40 transplants in terms of how many liver patients they acquire. Every single one of these patients is a very important number to add to the power of the statistics that we have in this situation.
Well, and I think Keith Linders, who got a study,
Elizabeth Carey, she's the PI at Mayo Clinic.
and it would be nice to be able to do this in pediatrics as well, because I think
Especially if you end up finding it, because you're treating them earlier, you start treatment therapy earlier. I mean, I had one patient with PSC who started with small duct disease, and at the time, this was a long time ago, but he eventually developed large duct disease. And then it was time to transfer him to adult care.
So could it be, if you have an adult, 2 or 3% of the adults with small duct, this is a point that I keep raising, sorry, that this disease they're just early in diagnosis, and so that's what you're thinking, that
It's
just haven't gotten
likely,
their
but
involvement
really
as well.
nobody really absolutely knows if these are 2 diseases or phases of the same disease.
Yeah.
The only way to find out is to the way you study disease is you take snapshots from a movie and then you try to reconstruct the movie.
Yeah.
So,
and there's the overlap, and I think the overlap in my mind is not just, there's a scope of it. Because I look at some of my PSC patients, they have ANA, anti-smooth muscle antibody. I mean, they have many of the same antibodies you see with, autoimmune liver disease. And so I think there is overlap between these 2 diseases. And I think some of them may have primarily within the liver and the small bile duct disease rather than the large bile duct disease.
I have a question for the adult colleagues. When you have your PSC patients, how often at the beginning and how often afterwards do you screen them for other autoimmune disease, including celiac and thyroid disease, or lupus or whatever that could be associated with? I do it on a yearly basis, or you do it only once?
Once and then sit back.
That's it.
If they come in telling us that they're losing weight and don't know why, they're going to get another TSH or another TTG from me. But truly, it's really the first time.
My patients I'm fairly aggressive with. I do it every 6 months. But celiac, I probably overdo it because it's just the same requisition that I get. So I don't have to keep sending them different ones. But it's mainly TSH and celiac I check for, and otherwise it would be clinic for lupus and other autoimmune diseases.
Ahmad Hassan in our group in pediatrics actually looked at the association between celiac and autoimmune polyglandular syndrome, and showed significant association between the two, which was not described before. So that kind of opened my mind into, autoimmune diseases, birds of the same feather clustered together, and the idea is that I would go ahead and screen them yearly, regardless of symptoms. So are you going to treat your patients now with vancomycin?
Think about it. Yeah. I have one who's post-transplant, and he's still on it, but I don't think it's changed much of anything. He doesn't want to come off of it, and his insurance company's paying for it, so I'm keeping him on it. But he's had a couple of biopsies along the way because he's easy with the transplant. And so maybe we've stabilized his disease, but I don't think we've improved it.
Yeah, it'll be interesting to do more data on it. And we're going to look into our 9 patients that we put on vanco post-transplant, kind of get what was the long-term outcome in these patients.
How many never respond? I mean, I've had patients that from the get-go have never responded.
Well, I had 3 that didn't respond very well, but I wasn't sure how much of it was compliance versus how much of it was the medicine versus the brand of the medicine. But all the rest, I mean, their numbers got, I had one of them that ended up getting eating disorder, getting admitted to the hospital. And I said, I'm done. So, with the vanco, because it was much more complicated. But, yeah, so what percentage yours don't respond?
A few,
Yeah.
but those that have not responded have already had significant ongoing disease for some time.
Okay.
So that's the first thing, and some of them do not respond at all to that. But I have not tried to go up significantly on the dose either. So that's another thing that we might do as well.
Let me flip the question back. What percentage of your patients with PSC do you put on treatment? Because I'm trying to figure out who gets it and who doesn't get it.
I will try it on everybody with PSC. So historically, more than 50% of our patients are on vancomycin. The ones that were not on vancomycin had been tried on urso and responded, and now that was a long time ago. Most of them are in the adult sphere now. So most of our patients are on vancomycin.
Yeah, all of mine I treated with vanco because they have research studies, but I have to get them to agree to it. But most of them come to me because they want to be on vanco because they read papers and stuff. So, yeah. Anything to add?
I mean, I would agree. I work with Dr. Cox and work with him as a fellow in the study. And so I would say that we probably get a call every other week about someone needing to be treated. And I think part of, a significant amount of my patients have been successfully on vanco and done well. I haven't been as brave as Dr. Cox on taking them off. So I keep 500 3 times a day. But one of the struggles I do find that when we get calls and someone isn't responding or one of our patients stops responding, it's usually a brand. Actually, they don't switch to the pharmacy. So I just recently had that.
I think
patient who didn't respond.
I've seen this also.
Or we
the
get
brand
calls
change.
and say, well, I tried vancomycin and it didn't seem to work. And it's usually because of the brand. So like Dr. Cox says, it's a blue brand that tends to be the only one that seems to have true efficacy. So we take a lot of time trying to get that at the pharmacy. But I've had many similar patients that have been on Remicade with one-time elevation of liver enzymes. Weren't sure if it was Remicade, but they weren't responding on Remicade. They're going up and on a dose, and putting on vanco was off Remicade, doing fantastic biopsies and normal. And so we're getting calls, and I just got a call 2 days ago on a patient on these Coast, so it's interesting treating, but seeing just a significant response in the patients on the right dosing and the right brand.
What's the brand that does it again?
So I've always used on brand, which was by Pharma initially. So we've kind of tracked this dose on when it got sold and when it went from pharmaceutical company to pharmaceutical company. But that is the brand. They make both a generic and they make the brand. So it's sometimes easier to get the generic through the pharmacy because the cost is
No, but you said there's one brand that doesn't work.
Acorn.
Acorn.
And Alvogen has a similar capsule, so we had some issues with Alvogen. Although I found that the one 125 has a different capsule.
Yes.
And they seem to do okay on the 125, but the 250 has the same capsule as us.
So as an example, my daughter was on A&I, the insurance company insisted we go to Alvogen. Within 2 weeks, she started to get diarrhea and her liver enzymes tripled. And so this was still within, they were very low, and so this was still within just normal limits. But the fact that that happened in 2 weeks, we switched with, it was enough evidence to switch back to A&I.
Well, I was surprised. I saw a patient in clinic last week, and she was on Alvogen. I said, how come she's doing well? Let me see your capsules. And it was 125
Yeah.
milligram brand, and the capsules looked more like A&I. So,
So it can be the inert ingredients, there's something about the way they're capsulized.
Now, my impression also, and you correct me if I'm wrong, is that our adult colleagues always are, of course, skeptical because you see the other side of the coin, which is quite progressive PSC, and there has been so many disappointments with everything we've tried so far. Does that color your attitude towards PSC, or you're still gung-ho about trying anything?
Well, the problem is there's nothing else now anyway, so this is as good as you get. I'll use an analogy that I found is that, for autoimmune hepatitis, budesonide really ought to work great, but it doesn't.
Yeah.
And the reason it doesn't is because we only save it for the people who are failing therapy. So as an adult, if you're kind of failing standard, this may not look as good as it does in pediatrics because you're applying it to the worst of the worst.
Well, always the few patients that are outliers can kind of teach you quite a bit. So I had a young man with common variable immune deficiency who got norovirus infection. I couldn't get rid of it. The only way that I could get him to get better, I actually asked him to open up the budesonide capsule and take one open and two closed, and his diarrhea improved dramatically. However, budesonide did get worse on his liver, because they do get chronic liver disease from CVID, and budesonide in a cirrhotic patient is a no-no, unfortunately.
it's
He needs a
interesting.
bone marrow transplant.
It's interesting. I have families ask me, should they use Vanco on autoimmune hepatitis? And I say, well, it's not the standard therapy. But I did have one patient that wasn't responding to steroids or any immune modulators, and I gave Vanco, and the kid got better. So, but I've not used it in any other patient with autoimmune hepatitis.
Well, I had an adult that came to me about this patient that had features of autoimmune hepatitis that was not being able to get weaned off her prednisone, and I told the physician, try Vanco, and she was able to get her off.
So I think that we need to look at this too at some point, particularly those that aren't responding.
So one more comment about the brand. We do have a liquid kit brand made
Yes.
by Cutis Pharma called First Bank, and they have agreed to donate for all of our clinical studies for vancomycin. So if any of you are doing clinical studies, let me know, and I don't know how far that's going to extend, but that's what we're using for the FDA trial through Mayo Clinic.
And they're so much cheaper than the pills.
Yeah, they're about a third the cost. They've gone up since they were FDA approved, but they're more expensive than the formulation of the liquid kit, the IV formulation, but they're great flavored, they're pH balanced, and it's an easy way to go.
Is this going to be at a Canadian site as well?
That was, I'll talk to you afterwards. We've substituted Mayo, Florida for Canada.
Oh,
Sorry.
You have it easier in Canada because your people collaborate better. Pediatric hepatologists, it's like herding cats.
Yeah.
That's interesting.
Well, no, one of the reasons is because in Canada, there's less centers.
Yeah.
Yeah.
So the number of pediatric hepatologists in Canada is much smaller, and